get a chance to fill out the survey. Perfect, thank you. Okay, so today we have Dr. Parson with us. She's an OBGYN, so she will be the star of the show for most of this meeting, but we have a few things to talk about first.
Yeah, so as you guys heard before, for every meeting, our goal is to inform, excite, empower, and involve all of you guys. Has a prompts read on there. The purpose of this meeting is for our speaker, Dr. Parson, to inform all of you guys and answer your guys' questions. And then to excite why we're talking about, or why we're here gathered. If we're successful, we'll be more informed of the specialty of OBGYN and her experiences as well. And empowering, we're all looking for you guys to come with ideas and the focus to further progress and enhance the pre-medical program here at Carroll and also around the community here in Helena. And we involve all of you guys to have these questions and be open to coming up, and we would be happy to answer any of you guys' questions you may have, and I'm sure Dr. Parson would be as well. So, really quickly, the COVID update. So there's been an increase in 8 cases of COVID-19 in Lewis and Clark County. Fortunately, there's 0 deaths that have occurred in Lewis and Clark County, but there's been a large uptick of the total number of cases in the state of Montana, number being 1,082. And unfortunately, there's a total of 22 deaths in the state since the last update. For important upcoming dates, I mentioned previously the career, or at the last meeting, the career and grad school fair. There should have been a link sent out via email to all of you guys, and also the individuals who are on Zoom, so you can follow along. The screen is being shared with them on Zoom, right? Or not screen, it's okay. So the link that is on the upcoming dates, just to show you guys how to access it. Wes asks that you RSVP to these events. One of the reasons for attending the fair is that organizations such as organizations and institutions such as Des Moines University that have DO, PT, PA, and various other public degree programs in medicine and health sciences will be there. Georgetown University, biomedical graduate educations is something that they offer. Pacific University, which offers PA, health admin, pharmacy, PT programs, and University of Nebraska Medical Center program, which offers graduate program and interdisciplinary biomedical approaches. These are just some of the opportunities, and I'm sure they'd love to answer the questions you guys may have. But in the email, it indicates that once you click the registration button for the fair,
I'm already registered and you're on my account.
Oh, I see.
That's the issue.
Okay. Is there a way to sign? Okay. So on this link provided here on the slideshow, and that link has been sent to you guys. Once you click that link and register for the event, it's very important to register for a group or individual session, as this is virtual, this career grad school fair, and you can attend as many events as you would like, and there's different time slots for everyone to attend.
Okay, so just really quick, the Health Science Department wants to put on a BLS course at Carroll. So if you are not already BLS certified, I would strongly suggest doing this because it's hard to find BLS certification in town if you don't like work at St. Pete's $50. There's an online portion and an in-person portion. BLS lasts 2 years. You're gonna have to recertify for the rest of your life every 2 years and do this course. But I strongly suggest it because if you want a clinical job, the BLS course is what you need. And you can email Kelly Parsley. I sent this out in the email earlier this week, so all of her contact info will be there. All right.
Hello.
Yeah.
Hi everybody, I'm Jecca. I am an OBGYN here in town. I can't sit still to save my life, so I'm just gonna back these up and I'll kind of walk and talk as I'm chatting with you. Can I just get a show of hands to who are freshmen in here? Sophomores? Juniors? Seniors? Okay, so we've got a good mix. This is gonna be really informal. Please interrupt me if you have any questions. And I do go by Jecca. There is a doctor, in my name, but please come Jecca at this meeting, okay? We can go to the next slide. Kayla asked me to come and talk with you guys and gave me a few talking points. I'm a champion procrastinator, so I did my slides yesterday and today. So a little bit about me, obviously, we covered the first part. I come from a massive family. I'm the third of 10 children. My dad's a psychiatrist, which gives you a little hint about why there are 10 kids in my family. You gotta be a little special to be a psychiatrist, and he's definitely that. My family's also very heavily Navy, so my dad's a Navy psychiatrist. He retired after 30 years. My husband is a Navy SEAL who did 15 years active duty. I have 3 siblings who are currently active duty as well. A diver, a corpsman, and then something with bombs. We're also a pretty heavily medical family. So my dad and I are the only doctors in our family, but I have a sister who's a paramedic, a sister-in-law who's a nurse, the brother who's a corpsman, obviously, and then 2 siblings who are pre-med currently. Not a native Montanan. I was born in Virginia, moved around with my dad being military, and so I've kind of lived all over the US and even in Guam for a small stint in my childhood. So pretty eclectic places growing up, if you guys have any questions about that and how that can translate to experience or things to talk about during med school interviews. I went to Old Dominion University, which is in Norfolk, Virginia, for college. I chose that because I met my now husband when I was in high school, and his career was pretty set. He could be stationed in 2 places, and so I applied to colleges that would be there because we were already pretty serious, and wound up getting into ODU, got a full ride there, and he was stationed in Virginia as well, so we wound up there. Same thing with medical school. Eastern Virginia Medical School is right down the road. It's in Norfolk, Virginia, and I chose that purely based on location. We can talk about, other reasons for choosing med schools and all of that if you'd like. But to be very realistic about it, I knew he wouldn't be stationed anywhere else, and I didn't want to go anywhere without him. So when I got in there, I chose to stay. And then I wound up going to University of Vermont Medical Center for my residency. It was my second choice, and again, I'm happy to talk about that process and kind of how to choose residency, which I'll go through in some of my slides. Okay. So undergrad at ODU, obviously this is where you guys are. It's been a little bit for me. This was 2007 to 2011 for me. I majored in biology. I minored in biochem. It's a very boring major and minor for a pre-med student, but it did the trick, and I think I had enough life experiences and other things to put on my CV that I felt comfortable doing that. At ODU, you had to have a minor in biochem. It was only 2 extra classes to get that minor, which is why I chose that. It also was very preparatory for medical school. I was part of a sorority. Do you guys have Greek life here? Cool. So I was part of a sorority that took up a big chunk of my time. AED is a pre-med honor society that I was a big part of during my undergrad. I worked full-time about 30 hours a week during college, all 4 years, as a phlebotomist at the hospital. If you don't have medical experience, something like that is really easy to get a certification for, and a good way to get medical experience. So I unfortunately had to take a gap year between high school and college because of some medical reasons that only took up about 6 months. And then after that was able to, well, I basically was like, what am I gonna do until I start college? And so I took a phlebotomy course, got certified, and then wound up working in a pre-op clinic at Norfolk General Hospital all through undergrad. I met a lot of people that way, a lot of people that I wound up shadowing, a lot of people who wound up being in the admissions process through my medical school, because it was all on the same campus. And so I thought that that was really beneficial. I have a few friends who did EMT, did scribing throughout college. So definitely doing something from a medical perspective to get that experience to be able to put on your applications is key. Shadowing, we kind of touched on that. My first shadowing experience is a guy, it was a nephrologist who was actually my dad's senior resident when he was an intern. He is now retired, but I met him when he came storming into the lab, furious because one of his kidney transplant patients, their labs were not sent stat. And the plan had been, get the labs done, go see him in clinic, he'd have the results and be able to talk to him. If you're personable enough, even somebody who's spitting mad at you, you can turn it into a good opportunity. So I wound up shadowing him for almost a year, and although obviously didn't go into nephrology, it was really helpful to have that experience, number one, but also to have it to be able to talk about it during interviews and on my application. You guys are gonna hate me, sorry. I did something called the BSMD program. I didn't have to take the Mcat, so I can't talk to you about that at all. It's a joint program between ODU and Eastern Virginia Medical School. They also have other programs with Virginia state colleges where basically you apply as a freshman. So you had to have done, I wanna say it was intro, bio, chem, physics, and I think in your second year you had to have you applied your I guess winter of your sophomore year. So you had to have done the first semester of organic chem as well. So got to do all those, and then they based it on your SAT and ACT scores in addition to your college GPA. So sorry, I can't talk much about the Mcat process. Kayla was kind of mad at me when I told her that as well. And then applying to medical school, obviously my experience was very different than a lot of yours will be. I got into EVMS as a sophomore, and so it was a big weight off my shoulders. I had to keep a certain GPA. I had requirements for shadowing and research and other things like that that were relatively easy to fulfill as a college student, and was then able to head on to med school. Any questions about undergrad at all? No? Okay. So medical school, you guys probably know a lot of this, and so I tried to keep it pretty brief. My school did the first full 2 years as didactics. A lot of schools are now moving to it just being the first 18 months and condensing that so that you have more time in the clinical years. I loved M1 and M2. I quit my job, and so having worked full-time all through college was very busy. And so to go from that to only having to study in medical school, that being my only job, was awesome. So I'm a morning person, I always have been. I would wake up, I would study, I would ride the train into school, I would study for that half hour on the train, go to my classes. I was an in-person class kind of person. I just found that I focused better. And then normally I would study for an hour or two after classes were done, and so I kind of had like a 9-hour day that I did and organized for myself, and then evenings and weekends were pretty much free. I'm pretty organized as a student, and so I didn't do a lot of night before, like 100% cramming, but you know, you do a little bit of that here and there. It was so much fun, guys. I can't even tell you. It was like the best time because you really just don't have any other responsibilities, and If you want to sleep in the next morning, you can, and there's nothing to worry about with that. I got involved. I highly recommend that you guys do the same, and this goes for both in undergrad and in medical school. These are just a few of the things that I did. So a little bit about my story. My mother, when she was pregnant with my 8th sibling, John, she had placenta previa. Anybody know what that is? Okay, so when you're pregnant, you guys can tell I'm growing a human in here, the placenta has to develop somewhere within the uterus. And it's attached to a wall of the uterus. It can be in the front, it can be in the back, on one of the sides, or at the top. It can also be at the very bottom, covering the cervix. And you guys can imagine, if you've done anatomy, as the cervix dilates to allow a fetus to pass through, if the placenta is over it, that is basically the baby's lifeline. That's how the baby gets blood and oxygen and everything. And so if the cervix dilates and this placenta is on top of it, the mother and baby will often bleed to death. This was one of the reasons that women hemorrhaged and died in childbirth before modern medicine. So we lived in Guam at the time that my mom was pregnant with my brother John, and this is this tiny little island that's like 36 miles long in the middle of the Pacific Ocean. And they didn't have the ability to care for her. And so they said, sorry, you have to go to Okinawa. So she spent about 3 months of her pregnancy in Okinawa, wound up having a stat C-section when she had a large amount of bleeding. And my brother was born at 34 weeks, and he was completely blue, cyanotic, which basically means that he wasn't getting oxygen for some reason or another. He's one of the kids in my family who's pre-med right now. He's 20, and so back then, 20 years ago, ultrasounds just weren't that great. And so they didn't pick up at his anatomy scan that he had a congenital heart defect called transposition of the great arteries. So my mom was being sewn up on the table, and they were doing an echo on my brother a few feet away. And they turned to my mom and they said, he has a heart condition. We don't have the ability to care for him here, so we need to send him to California. So while my mom was laying on the table, she got to blow a kiss to my infant baby brother, and they took him and they life flighted him from Okinawa, Japan to San Diego. He underwent heart surgery at 11 days of life. And my mom, this amazing woman that I can't even imagine, I have a little boy at home and obviously have been through a delivery before. At 2 days postpartum, she got on a flight from Okinawa to Japan to be with my brother, and my dad flew from Guam to meet him up there. So pretty dramatic stuff. You can bet that I talked about this in my personal statement. So basically, that experience really shaped me. It's the reason I went into medicine. You know, when I was a kid, I was like, oh, I'm gonna be a doctor like Dad. That actually, as a 12-year-old, which was when my brother was born, that shaped me. And so I always thought, I'm either gonna go into OBGYN and do high-risk obstetrics, or I'm gonna go into peds cardiac surgery. And so at the very beginning of medical school, I joined both of those clubs, wound up holding leadership positions in both of them, and wound up doing a lot of shadowing and a lot of research in both fields. Between your first and second year of medical school, this might change depending on the school where you are, especially if they are condensing the first and second years down. We had the golden summer between M1 and M2, where you got to basically do research. It was a couple months off. You didn't have much that you had to do, and so most people chose to do research or something that would further elevate their application status. And so I did some peds cardiac research, wound up getting published in that, and then developed some relationships for some OBGYN research at that time. The Hopes Clinic was basically the student-run clinic at my medical school. A lot of places have them. I highly recommend them. I thought it was the most amazing experience to be able to go in there and as a first and second year medical student actually do that clinical work that you really don't typically see until third year. So if I can give one piece of advice about looking at certain things for medical schools, obviously make sure you agree with their mission statement, look at where they match people for residency, and all of those other things that you'll probably be told by your pre-med advisors and all of them. But also, for me, the Hopes Clinic was really great. I was on the admissions committee in medical school. Again, things may have changed since that time, but I actually conducted interviews. So my first year, I was just the student who would sit there and be part of the interview process. My second, third, and fourth year, I was running the interviews, I was scoring the candidates, and then I would present the candidates to the admissions committee with my recommendation for admission or not. So I think that I have a little bit of strength when it comes to talking with you guys about what it is that medical schools are looking for. And so you can certainly pick my brain about that as well. We did this thing called haunted hallway. Norfolk's not a very safe place, and so we would turn the hallway into our, the hallway in our main medical school area into an area that kids could trick or treat, and they would come by. It was really fun. EVMS cot shelter, once a year we hosted the homeless shelter in Norfolk and made food for the residents, basically had to check them in and out of the shelter. Again, just really cool stuff, kind of the humanity aspect that can get lost sometimes when you're just stuck in books. It kind of reminds you of why you're doing this. And then research we talked about. So choosing a specialty, I kind of went into why I had thought about surgery versus OBGYN. I hope that people aren't recording this and I'm gonna show this to all of my gen surg friends because they'll hate me. Basically, I did my general surgery rotation second, or was it third? I can't remember now. Anyway, I did it at the beginning and then OBGYN was next. And general surgery residency is 5 years, and then you can either go cards to peds or peds to cards if you wanted to do peds cardiac surgery. So I was looking at probably about 8 years of training, and 5 of that would be in general surgery. And I got to gen surg, and I wouldn't say I hated it, but I didn't love it. And if there's one thing that you have to do in medicine, it's you have to love what you do. There has to be a reason that you can work 90 plus hours a week indefinitely. And if you are not absolutely in love with what you're doing, you're gonna get burned out. So I had this moment of panic, this like existential crisis of, oh my gosh, now I'm in the same place as every single other one of my classmates who don't know what they're gonna do with their lives. But it turns out it was completely fine. Everybody is like that at some point in medical school. And my next rotation, I was on OB, I delivered a baby at 2 a.m., damn near dropped the kid. It was her like third or fourth baby. And at my medical school, when they delivered babies, they would break down the bed. So the mom's legs are up in stirrups and you're standing in front of her and you're gonna deliver the baby. And I just, in my mind, was like, okay, the head will come out and then it will restitute and then I will do this and the baby will deliver. And basically the baby just like shot out and like thunk, like hit me. And I like did this like deep knee bend with the kid in my arms, like kind of squished up against the mom's like perineum. And my resident over my shoulder was like, nice catch. And it was exhilarating. It was so cool. So I got to deliver this baby, be a part of this wonderful moment, handed the baby to mom, and I was like, that was amazing. Like I could see myself doing this. And then I was about to call my mom and tell her, I think I'm gonna be an OBGYN at 2 a.m. She would have loved me. And we had to run downstairs for an emergent delivery that was happening in the parking lot. And that was the moment when I was like, all right, like the signs are all here, the heavens are opening up, this is what I'm meant to do with my life. So it was really cool. I had that moment that I think most people hope for in medical school, where you actually get a very clear, this is what I like doing, this is what I love doing, and I can see myself doing this forever. Obviously, OB is only 1/2 of it, so then I switched to the gyne portion and was lucky enough to find that I loved it just as much. So that was kind of how I chose a specialty. I do think that your work-life balance, which I hate that term, I think that when you think about what your life is going to be like, you have to think about those things as well. How many hours a week you're gonna work, what type of call schedule you're going to have, all of that. But truly, you have to love it first. Applying for residency, mine was really Location first. My husband is very outdoorsy. He said that he wanted mountains and snow and hopefully water. So we applied to a bunch of places like that. He also said that he was hoping for not the biggest city in the world, but he could handle if there was a big city. So we sat down with this website called Frida that has all of the OBGYN residencies on it, and basically picked through location-wise what we could both live with, and then I went through and did this. The program type, I wanted an academic center. I didn't want a community-based. Those are the two types that you can have. Class size, I actually wound up matching at a place that only had three residents per year, which is the smallest OBGYN residency that exists in the country. There are only 2 of them. And I wouldn't have chosen that right off the bat, but it wound up working out well. And I did rank them second, knowing that I might not love the small class size, but there were enough pros about University of Vermont that it actually was excellent. Faculty involvement and support, fellowship opportunities, research opportunities, what electives they have available, networking opportunities. These should all be things that you guys consider when you're looking at a residency program. Obviously, once you've decided on your specialty. So then residency, this is just gonna be a bunch of photos. Residency is really fun. It's hard, but it's really fun. So this is where I went. This is University of Vermont Medical Center. It's beautiful. It's in Burlington, Vermont. It's very picturesque. Burlington, I think, is a town about 40,000 people. It's a big college town as well with 2 universities in it. And it is the big city in Vermont, 40,000 people. So we were the tertiary care center. We got referrals from 3 hours away in upstate New York and things like that. But it was really nice lifestyle-wise because you could live, 15 minutes away from the hospital and be out in the middle of nowhere if that's what you wanted. It was great. So a lot of history there as well. This is a picture I took from labor and delivery one stormy morning after having been on call the night before. Just really beautiful place. The Lake Champlain is I want to say it's the biggest freshwater lake after the Great Lakes in the US or something like that. And then the Adirondack Mountains right behind it. Just really beautiful, lots to do there. So enjoyed my time there for sure. Worrying noises. So this is a photo that was given to me with permission by the patient, I promise, the one on the right. Residency is a lot of work. You typically walk around with multiple pagers like that, and yes, people still carry pagers like that. So that was when I was the gyne chief, the OB chief, and the night float chief all in one, hanging out my 3rd year. I also was about, maybe 9 months postpartum in that photo. Still pumping and breastfeeding my little guy, and obviously had not slept in a long time. I've recovered since then. That's a C-section that I was involved in. Baby's just born, just clamping the cord there. Just fun stuff. There aren't many photos that you take in residency of you actually working, so these are probably the 2 that exist in my life. Just showing you guys. This is the group that I graduated with. They're awesome. So OB is 4 years long, 3 of us per class in our matching Patagucci's, as the girl in the teal in front, Catherine, she coined that. The department asked us what we wanted for our Christmas present, and somebody said they wanted matching Patagonia fleeces, so there you go. Obviously, in OBGYN, you'll catch that there's only one guy in there, so definitely becoming a very female-dominated field. And then I think the next one is just the same group of us at my graduation, which was just about a year ago. The last group of photos after this, I included my class. This is Sam and Erin. Sam is the brunette, Erin's the blonde. Sam is now a family planning fellow at Pittsburgh, and Erin is a gynoc fellow at Brown. These girls, they're my best friends in the world. We went through hell together for 4 years, and we still, I would say, talk, at least every other day. We have a group text going that is, a lifeline. So these are people that you'll talk to for the rest of your life. So when you're interviewing in that interview process, also see what the relationships are like between the co-residents. If there was anything malignant about the program, I would not have chosen to go there. Okay, enough of all that. So then attending life, that's my little guy, that's Leif. He's 3 now, so obviously a little bigger than that. Things that you need to think about for attending life, and again, I'm happy to answer any questions about why I chose mine. Private practice, hospital employee, or academic practice. Those are the 3 options as an OBGYN. I'm in a private practice. I think that it fits very well for me. I like the autonomy of being in a private practice. I like having the ability to change things quickly. When you're in a big hospital-based group, or a hospital employee or an academic practice, there's a lot of bureaucracy. And personally, I just don't have time for that. My job is to take care of patients. And if I'm trying to say, be able to start induction, this is actually a great example. We just changed this in my clinic. So recently, if you were being induced, there's this thing called a cervical ripening balloon. Basically, it's barbaric. You put a balloon up through the woman's cervix, inflate it with saline, and then let it stay there for up to 12 hours. And it dilates the cervix manually and makes it more receptive to Pitocin the next day. For some reason in my office, we were not able to do that in the office setting. The patients had to go to labor and delivery for it. And then that meant that we had to leave clinic, go over, place the balloon on labor and delivery, and then basically come back to clinic if that's what needed to be done. We just didn't have the infrastructure to do it in the office, and I said, why not? Let's change that. And so within a week, we had ordered the supplies, we came up with a protocol, and it was changed. Something like that would have taken months where I went to residency. Committees would have had to meet to discuss the pros and cons of doing it in the office, and what are the legal ramifications and all of that. And instead, as a small practice, we were able to sit down, us physicians together, go through the data, understand that yes, actually people do balloons, then send folks home with them. So doing it in the office and then sending them to L&D should be fine. And we were able to change it quickly. So really it comes down to, what do you want out of your practice? What do you want out of your medical career? And going from there. Work-life balance, again, I loathe this term. It's your life, right? You have to love what you're doing. If you love what you're doing, you will probably be fine with whatever work-life balance comes with your career. There's also a lot more opportunity nowadays to be part-time, to be 80% time, whereas that wasn't an option 10, 20 years ago. And so I don't think that, I'm not saying it's not important. It is extremely important to consider these things. But I also think that if you really love what you're doing, you're gonna want to continue it. All right, I think the last thing was just a couple things that Kayla sent me that she had asked that I cover. COVID has changed my practice quite a bit. Unfortunately, pregnant women, we know, are not more likely to get COVID. They're not more likely to die from COVID, but they're more likely to get sick, and they're more likely to end up on a respirator or a ventilator. When patients are sick with COVID, really sick, a last-ditch effort is to put them prone, so face down while they're on the ventilator. And if you have a big belly, that can basically not be possible. And so women do get sicker with COVID. Initially, we thought that pregnant patients did not transmit it through their placenta to their newborns, but unfortunately we've now found placentas that are infected with COVID. We found babies that are born with COVID. We also know that women who get COVID early in pregnancy, they're at risk for what we call intrauterine growth restriction, where the babies are smaller, which leads to preterm deliveries. So both as a provider, as a pregnant woman, COVID has changed my practice a lot. I'm very careful. I'm very careful for my patients and try to convince them to be cautious as well. We also had all of our non-emergent gynecologic procedures postponed because of COVID. We just had to wait to do them. It took about 8 weeks, I would say, to catch things up, which in the grand scheme of things is not terrible. But for that woman who's bleeding, you know, gosh, going through a pad every 2 hours, not quite anemic enough for it to be an emergency, but terrible enough that she wants her surgery, it's a long time to wait. So that certainly just temporarily change things, and I would say we're back up to full speed now. Would I change anything about my course? I don't think so. I don't think so. I love where I'm at now. I think I had a really great college, medical school, and residency experience. I learned what I needed to. I feel very confident coming out. I also chose to come to a practice that had a senior partner who was willing to take me under his wing if there were any things that I was not comfortable with. And so I don't think I would change anything at this point. And then she asked me, do I like OB or GYN better? I can't say. I don't know. Gosh, I would never, like your friend you were talking about who's a gynecologic surgeon only, I don't think I could give them up. I went into OB thinking I would do high risk obstetrics, and I found that I loved gyne so much that I couldn't. So right now my split, I was asking Jack, my senior partner, we were doing a C-section actually right before I came here, and I said, what do you think our split is? Are we like 50-50 OB and gyne? And he said probably 60-40, a little heavier on the gyne side. And so for example, today I did a hysterectomy this morning. Then I did a DNC, which is a dilation curettage for a woman who had a miscarriage 3 weeks ago, but didn't pass all of the tissue. And so she was still having bleeding. So we went in with a suction inside of her uterus and cleared out the rest of the tissue. Then I had patients in the office for the remainder of the afternoon, helped Jack with his C-section tonight, and I'm inducing 2 patients tonight, so I'll deliver 2 babies probably tomorrow. So in the office, probably heavily gyne patients that I saw today. I saw a couple OBs, but yeah, it's a little more gyne than OB, and I think that that's perfectly fine. I couldn't give up one or the other, for sure. I do think down the pipeline, there will be a split in OB and GYN. People like lifestyle too much to do both, and so I think that there are gonna be those people who do laborist model, and then those people who are gynecologists only. So that's what I've got for you. Do you guys have any questions? I'll open it up at this point.
We have a Zoom question.
Oh, yeah.
So one of them is, how did you handle the financial situation of medical school if you weren't working?
Oh, yeah, loans. Loans. I will be paying off loans forever. So I took out student loans. I was very fortunate. I got married during college, and my husband had a job. And so when I went to medical school, we only had to take out loans for tuition. I did not have to take out any for room and board, for living expenses, anything like that. And so we were very frugal, and we lived off of his income, and I went to school. I would say just about everybody I know that I went to school with took out loans. I know one girl, she's in a peds cardiac, just cardiology medicine, not the surgical side, so a peds cardiology fellowship now. And she worked 12 hours every other Saturday as a paramedic, and that was all she did. And she was the only person I know who worked during medical school. You just can't. I mean, your first and foremost job is to do well. Your entire remainder of your career depends on your grades and your board scores and all of that. Although I'm hearing not so much scores anymore for step one. Just step one. None of us worked. We all took out loans. One of my colleagues that I know has about $400,000 in debt from a master's degree and then medical school, and she is banking on something called public service loan forgiveness. And so she's doing a fellowship right now, and by the time she finishes, she'll have been in a public service position for 7 years, and you have to do it for 10 in order to qualify. And so she's just paying her minimum payments right now, and then we'll hopefully have her loans wiped free at the 10-year mark. I won't have that. I'm private practice. So I'll just keep paying them back. Any other questions? Yes?
Do you work with any PAs in your practice? And if you do, how do you feel their knowledge base compares?
Sure. So I don't have any in my practice specifically. I worked a lot with them during residency. I would say that the PAs are highly knowledgeable. One of the PAs, actually Stephanie Stahl, that I worked with in Vermont, she taught me all about having patients on TPN, which is total parenteral nutrition. Basically, if someone can't eat for longer than 7 to 10 days, their body will start to completely catabolize. And so you have to feed them through IVs, and it includes fats, protein, carbohydrates as well. Carbohydrates are really easy to get just through a normal IV, but TPN, you cannot imagine with all those other proteins and fats, it's very viscous. And so then you have to follow all of these levels in the patient and make minute adjustments every single day. Do they need more potassium? Do they need a little bit more fat? Do they such and such? It's really complex, and so she actually taught me all about that when I was an intern. I think it's highly valuable. I think that every level of education within the medical field, you can find something to learn from. One of the nurse practitioners in our practice in residency was the one who taught me how to do a pap smear that didn't kill people, right? Like, you go in doing pap smears and it hurts. And so she taught me a lot of techniques about how to make it less uncomfortable for women, and then also how to recognize abnormalities in the cervix. So I think that they all have really great skill sets, and you can find something to learn from everybody. Other questions?
How often are you on call right now with your private practice?
Sure, I'm 1 in 6. So there are 6 OBGYNs in town right now, and we split call equally. So I'm on call basically every 6th night, although we do a weekend at a time. And so I'm on, like 2 weekends ago, I was on call for the full 3 days. And so that's from Friday night until Monday morning. Then for the rest of the month, you know, if you're on call on a weekend, you might not have a call day that week, is kind of how we run it. One of the OBGYNs is going to be retiring soon, and so it'll go down to 1 in 5. And then I'm going out on maternity leave, so my partners will be 1 in 4 for a while. So that'll be pretty tough for them, for sure. 1 in 6 is really, really manageable. I've never been 1 in 5 before, except during residency when I was more than that. I'm not excited about going back to it, but it'll be fine. Yes?
Can you talk a bit about the interview process and what they look for?
Sure, yeah, I knew that was gonna happen. I knew that question was gonna come up. So my sister is doing her gap year right now. She just graduated from Notre Dame. And so I've been doing a lot of catching up on what is going on in the application process now, because it has changed quite a bit. So she's kind of schooling me on all of these different, gosh, I don't even know the acronyms. I can't keep track of them all. But all these things that I never had to do, right? So she's teaching me about all this, and I feel like what I can help her with is showing her what exactly in the interview process they want. So at least in my experience, grades and MCAT score, so you know, whatever GPA, both your sciences and your overall, plus your MCAT score were probably the highest ranking numerical values that we had on our ranking sheet. So you got the most points for those. But then other things that they looked for were volunteer activities, medical experience, how strong your personal statement was, how strong your letters of recommendation were. And basically, as the admissions committee member, I had to read through all of those and then give people scores based on them. You can't do much about your letters of recommendation, right, because you're not going to see them, but pick good people. And you probably, you know, grades are grades, do as well as you can. MCAT's MCAT, do as well as you can. Where you can really make a difference is during your actual interview and during your extracurricular activities. So what I looked for as the admissions committee member was consistency. If someone shadowed, you know, 1,000 different specialties, but only spent an afternoon with them, okay, fine. Like, sure, you're getting a bunch of experience, that's great. If someone did consistent shadowing or consistent volunteer work where they showed commitment, to me that spoke of a great strength in that person. Even if it wasn't necessarily the specialty that they wanted to go into, I thought that that was very important. Leadership positions, I think that that's very important as well. So not just being a part of a group, but actually holding a leadership position in it, and showing that you take that initiative. During the interview process itself, I think that humility and humor are the 2 best things that you can have going for you. So everybody's gonna have something on their application that they're not necessarily the proudest of. A lot of folks that I would interview with who really struck me as good applicants or those who had either had a bad grade in a test or a bad score, or something within their application that just, okay, you messed up a little there. And often what I would recommend saying, and what I've told everyone that I've ever counseled about applying to medical school, is find a way to turn it around. Like, how did you learn from that? And so if someone could come to me and say, look, I know that you're gonna see my, whatever, MCAT scores are graded so differently now. They were like, a high was 36 before, and now I hear like 500 something is,
528.
What is it?
528.
528 is the high.
It's like the same format, it's still like the same amount
Yeah,
of points
but they
each month,
just-
they just started at 518.
Okay.
Sorry,
What?
470.
472.
472 to
Gotcha.
528.
Okay.
I don't know why I said 518.
No worries, no worries. So, anyway, with something that was maybe not the best, if someone said, well, I had this score, I had this grade, and I realized that I needed to do better, I learned this about myself through that process, and you can see that I improved in X, Y, and Z. I think that that's one of the most important things, is showing that humility. Yes, I made a mistake, I learned from it, and this is how I moved forward. And I think that's also really important for you to know during an interview process in general, is being able to own up to your mistakes, but then show how you grew from them. It shows great character. The other part of it is just humor, right? It's gonna be a hard ride, and if you can kind of laugh at yourself and show that you have a good sense of humor about what you are about to embark on, I think that it shows that you're gonna be a strong student, and you're gonna be a strength to that university or to that program. You don't want a bunch of people who are all like, all right, I'm just gonna get through it, I'm just gonna do this. Like, you want people who are gonna enjoy themselves and bring something to the community. And then also showing, or asking, what's very important is asking questions about things that you would like to be involved in. So you guys are gonna hear this like ad nauseum from your pre-med advisors. Every place that you apply to, look at their website. Find out what kind of research that they are involved in. Find out what types of extracurriculars the students have available. Ask questions about them. Show that you're interested, show that you've done your homework, and that you really are wanting to come to that program. I think that that's the best advice I can give about that. Don't say you are, what did this guy say to me once? We didn't admit him. He said he was working in the ER, and he found that he was he nauseated? Something, just like he was absolutely appalled by a patient. And he said that for him, it was that moment where he realized he could get through that despite those feelings, that he was about to, like throw up. And I was like, well, did it smell bad? Like, what was it? Like, what was this experience? And he was like, I was just, ugh. And I was like, okay, human being you're talking about, with a soul. Probably not the best thing to say in a medical school interview. So, what other questions, guys?
I noticed when you were talking about when you were attending and you could either choose private practice, hospital employee, and an academic program. What exactly?
So being a teacher.
Being a teacher.
Yeah, so most people who work in residency programs are still clinical physicians. They still practice medicine, but a large portion of their time is devoted to teaching residents and medical students. You have to be a very special person to do that. Like truly, it is an undertaking to be developing a physician-patient relationship while you have someone looking over your shoulder. And especially in a field like OBGYN, it's daunting, right? You're seeing women at their most vulnerable. And to have people behind you as you're trying to connect with a patient is challenging. We had great teachers in Vermont. I mean, just excellent, excellent teachers who would bring you into the conversation, make you a part of it. They would introduce you as a member of the team when you were a resident or a student. And I think that that's really important. So if you have an interest in teaching, I think that's something that early on you should see, do I like that portion of it? Not just being in a didactic session, not just being able to teach the residents, but when you are actually seeing patients, Do you enjoy having someone else be a part of that relationship? I would love to do it, right? Like, I don't think I would mind it. I don't think my office is set up very well for it, but, you know, I've invited people to come shadow me during surgeries and such, and if St. Pete's would allow it, you know, during deliveries and all of that stuff. I don't know what's going on with COVID. You probably know a little more than I do, but.
I'm not letting anyone in right now.
Yeah, so that's the part of it, is an academic practice is basically, are you in a medical school or a residency program where in addition to your clinical responsibilities, you are also teaching residents? Any other questions, guys? Yes?
With your current practice being funded, you spoke a little bit about research. Do you currently have any ongoing aims with that in your private practice? Or?
No, I don't. Sometimes, you know, I'll get letters in the mail that are addressed to my office from bigger institutions that are doing studies and asking if I have any patients who would like to enroll. And I'm happy to help them, but in a small town like this, there just isn't the infrastructure to do any large-scale research. I think that the research scientist, right, the physician scientist, is one of the most noble career paths to choose. It's incredibly challenging to have both that ability to develop a relationship with patients, but also to then go back to the bench and do research from the beginning. I personally, I find that I'm just wanting to see patients. I'm not as heavy into research. I loved research when I was doing it in residency, when I had a good support system, but I wouldn't be able to do it here. I think you also asked about fellowship, right?
Yes.
I don't have any plans to go back to fellowship, and I think I touched on that as well.
Will you explain what fellowship is?
Oh, sure,
Not
yeah.
everyone may
So
know.
residency is after medical school. It's for OBGYNs 4 years long. Within the OBGYN field, there are then subspecialties. So gynecologic, oncology. They do 3 years after residency in a fellowship studying just women's cancers. They are a highly surgical field, and they are excellent surgeons because they're basically taking out ovarian and uterine and cervical and vulvar, vaginal cancers. And cancer distorts anatomy, so surgeries are much more complex. There are also subspecialties like reproductive endocrinology and infertility, so folks who need IVF, folks who have PCOS, things like that, basically, kind of the endocrine portion of OBGYN. There's the family planning, which is basically contraception, termination. That's its own subspecialty, and that's 2 years. And then maternal fetal medicine, which is high-risk obstetrics. And that's also called perinatology, and that's a 3-year fellowship. MIGS, which is minimally invasive gynecologic surgery, which is basically benign surgeries so surgeries for benign processes in gynecology that are also highly complex. So endometriosis, for example, causes intense scarring throughout the pelvis, so it can be very difficult surgeries. And so trying to do those without having to open someone up is its own subspecialty, and that's a 2-year fellowship. I'm trying to think if I forgot any.
That's it.
Yeah. I think that those are all the subspecialties within OBGYN. I like being a generalist, meaning that I kind of see women at their baseline. I was just talking with Kayla about how I've seen a patient recently who I know is beyond my scope of care, and so I'm looking for a subspecialist to send her to. So I think that's also one of the most important things about being a generalist, is recognizing where your limits are and knowing when to ask for help.
Will you talk a little bit about call schedules, like the difference between how in residency you actually like sleep at the
Yeah,
hospital?
sure. Home call versus hospital call. So in residency, if you are in OBGYN and you are on call, you're in the hospital. So right now, work hour restrictions, when I left, you couldn't work more than 84 hours a week. 4 hours of it could be didactic or finishing up paperwork and such. But you couldn't be in the hospital more than about 80 hours per week. The trade-off when you're an attending, depending on where you are, like for example here, I take what's called home call. So when I'm on call, I'm not necessarily sleeping in the hospital. Sometimes I do. If something's going on that is a baby's misbehaving on the tracing and I'm concerned I might need to do something like an operative delivery or a C-section, I will actually sleep in the hospital so that I'm available and can go immediately if something happens. Otherwise, I'm at home and basically I just get phone calls. If I need to come in, then I drive in. So I'll have some patients that are, maybe in labor, maybe being induced, maybe there's a post-op patient from a hysterectomy. They're all doing fine, they're stable, and so I can sleep at home, and then if somebody needs me, they call me and I come in. There's a lot of emergency department calls, which are basically, hey, can I talk with you about this patient? Do you need to see her now? Do you think that she's stable enough to go home and see you in clinic? That sort of stuff. Yeah. Yes?
What would you say is like the hardest condition that you see or deal with pregnant mothers or just women in general, and kind of like the hardest thing that you've had to deal with concerning like patient like conditions?
Pregnancy loss. With this, it's terrible. You can't hide this, right? So I wear baggy scrubs when I can, and I've had 2 instances in my career that were terrible. One was a woman who, because of religious reasons, couldn't have a male OBGYN physician. And I was 35 weeks pregnant, and she broke her water when she was 19 weeks along. And that's called preterm, pre-viable rupture of membranes. It almost always ends in demise of the fetus. And if the fetus survives, the fluid is so low that the lungs don't develop. They can get limb, face, whole body abnormalities because they don't have this cushion to develop in. The other thing that can happen is that the bag of water is a barrier. The vagina has bacteria that lives in it normally. The uterus is sterile. And so if you break that barrier, you now have ascending bacteria that can come up. And so women often get infected. It's called chorioamnionitis. The only way to treat chorioamnionitis is to evacuate the uterus. So this woman who was 19 weeks pregnant and hoping for a miracle, she became febrile. She had a tender uterus. She had pus pouring out of her vagina. And we told her that with her illness, the recommendation would be to induce her labor, and unfortunately that she would lose the baby. And it happened to be when I was on night float with the guy that you guys saw up there, David, the one male resident. He was my junior resident at the time, and we had a male attending. And so I was the only doctor on the floor who could care for her. And so I went in there and I said, this is the one time in my life that I've been sorry for being pregnant. It was terrible. We sat there and we cried together, and I said, look, if you need someone else, the men are here. If nothing happens overnight, you will not have to have them actually in the room and caring for you. And she said, no, I don't want to take that chance. I'll take you as the doctor. And unfortunately, I had to deliver her baby that night. So I would say that was probably one of the most challenging things that I've ever done. And then the other one would be a woman who was nearly full term and had what's called an intrauterine fetal demise. So the baby died inside of her uterus, and she was, like I said, just about term. And then I had to induce her, and I was sitting there with my belly, unable to hide it. And it's terrible. You never want to have something about you personally come in between you and the patient like that. You also never know what someone else has been through to try and get pregnant, and so it's hard to remind anyone of that when they're going through that amount of agony.
Thank you for sharing that.
No, of course. That got really heavy really quick, guys. Most of the time my job is so much fun. It's great.
Yeah.
Babies come out screaming. The kid that we delivered just before I came here, the mom was in labor and her baby was breech. And breech babies, their legs are up by their faces the whole time, and so when they come out, the legs just like flop up in the air. They just don't go anywhere. They lay on their back and the legs just have to go up because they've been like that for months. They're the cutest things in the world. So believe me, my job is normally like 99% of the time really, really fun. The heavy stuff happens sometimes, and again, being able to be there for your patient, just sit back, recognize the humanity of the situation. That's why you get into medicine. Any other questions, guys? Oh, we ended on such a dark note there. Oh gosh, I'm sorry. It really is a great field. Yes?
What's been your favorite moment then in your career?
My favorite moment? Oh, when I delivered my kid. I delivered him. So you saw her up there, Erin, the one who's a Gynecologic fellow now. I keep joking that she'll have to come here and deliver this one as well. So she was my obstetrician. I had an attending, of course, as well, since she was in residency. But it was just the most beautiful thing in my life. And as an obstetrician, I kind of knew too much about what was going on, and so my kid wasn't behaving well during labor. And I remember at one point I'm standing there out by the nurse's station, kind of rocking back and forth, dealing with it. And I see Erin come around the corner with her finger up. "You're having late, get back in bed." And I was like, what? And my baby was just not looking good on the monitor, so I had to go lay down. But yeah, it's being able to experience what my patients have been through, I think has made me a much better physician. And so even though that wasn't specifically a moment as a doctor where I was the one doing the doctoring, it has made such a huge impact on my practice because I've been through a delivery, I've been through breastfeeding, I know how challenging these things are. I've been through going back to work at 5.5 weeks and the tears streaming down your face as you drive in thinking, okay, I'm leaving my baby with somebody else. And then coming home and it being fine and watching your kid grow and just being like, okay, this is possible. It has made me a much better doctor. Yeah. Thanks for asking that. All right, guys.
We're rushing over 8 o'clock now.
Perfect.
So,
Let's do it.
Let's give her Dr. Parson.
Oh, wow. Thank you for having me. I appreciate it.
Yeah, and if you guys want to meet her personally or greet her, just say thanks personally after the meeting. I'm sure that'd be fine for the next couple of minutes. Otherwise, we're going to just end really quickly by referencing our next meeting's topic. So far, we're planning to speak about the road to medical school with specifics to the medical school process applying to and then undergoing those 4 years that we discussed. We're also thinking about having a guest speaker that's a medical student as well, but we're arranging that. We'll let you guys know more about that.
So just touching on that really quick, just watch your email. We're probably gonna change our meeting time next week about a half hour to an hour earlier. In case you missed it, Gender Studies is putting on a really good demonstration about drag and LGBTQ stuff, and I really urge everyone to go to that, no matter your beliefs on it, just because as a physician, those are things you're gonna have to deal with in the future. So we're gonna try and accommodate our meeting so that people can attend that.
Will it still be on Thursday?
Yes.
It'll be on Thursday. It might be 5:30 to 6:30, and it might only be on Zoom.
Because our guest speaker is gonna join us via Zoom.
And there's a class in here until 6:30.
Yeah.
So it might be only on Zoom.
Watch your emails.
Yes, definitely. But that will end with parting message.
Yeah, and then also regarding the dates, I think this weekend or the upcoming date for the required pre-medical meeting, I didn't mention it
Sunday.
earlier. What's that?
It's on Sunday.
Yeah, it's this Sunday, thank you. And that's you can RSVP, and there's different time slots for the respective year you are. And once again, I wanted to express our appreciation and thanks for Dr. Parson for attending and being here today, talking to us all.
Thank
And
you.
to end with, success isn't how far you've gone, but the distance you traveled from